Thank you, Dr. Hamilton, and everyone, thank you for trying to stay awake after lunch. I appreciate it. It's really a pleasure to be here with the distinguished faculty and Dr. Harrop. So without further ado, you're going to have some great talks later on in the course about basically SI joint diagnosis, different procedures. So we're not going to go too procedure heavy, but I want to go a little bit through some pitfalls and some pearls. And if anything I can teach you, it's I've learned it the hard way, so maybe I can help you not do that. That'd be fantastic. So, all right. My disclosures, some of which are relevant to the talk today. I'm not going to advocate use of any particular instrumentation. I'm going to show you techniques. So why are we doing this talk? Well, basically, there are a lot of times when you do something in residency or fellowship and you're not exactly sure all the indications or kind of what your attending is thinking of, and I really want to make sure we touch on that today. And I want to make sure that at the end of this talk, when you see that x-ray on the right, you'll realize what the patient had done and what went wrong, et cetera. So first of all, just briefly, why we do pelvic fixation. As most of you know, there's a very large mechanical strain across the lumbosacral junction, and that increases with the number of increasing levels you fuse. So there's a large cantilever force there, and that can lead to pseudarthrosis across the L5-S1 level. And basically, the sacrum itself, as Dr. Cross mentioned a few minutes ago, has largely cancellous bone, particularly in the ala. So to get the strength from sacral fixation, traditionally you're using tricortical fixation, which I know Dr. Sancer will touch on a little bit later. But basically, the cortical bone purchase in the sacrum is somewhat thin. The pedicles are very wide, so it's hard to get good pedicle fill. So basically, S1 screws, you need them. They're great, but oftentimes they're not enough. And basically, when you put pelvic fixation in and you engage the cortical bone of the ilium, you decrease the S1 pedicle screw strain by about 70%. So when do we do this? Well, a traditional indication would be fusions from L2 to the sacrum and higher. There are specific instances when pelvic fixation is helpful even in shorter fusions. So if you are doing a pedicle subtraction osteotomy at L4 or L5, typically that benefit from having stronger distal fixation because of the forces that we talked about. A high-grade spondylolisthesis, typically at L5-S1, when you reduce that, if you just have S1 pedicle screws as your base, we talked about the potential pitfalls of that. Also, patients that have osteoporosis certainly can benefit from engaging the cortical bone that they do have, paltry though it may be, in the ilium. And certainly sacral fracture fixation is another indication for this. So there are many types of pelvic fixation throughout history, and the ones up on the screen now are the most commonly used. The main differences that we're going to talk about today are between iliac and S2 alar iliac trajectories and the unique complications between each of those, as well as how to prevent that. You also can use these screws as a strategy for deformity correction. So for coronal deformity correction, for example, Dr. Lenke popularized the kickstand technique, where you distract across an iliac screw to basically push over a rigid curve, and that's a mechanism of coronal deformity correction. So pelvic fixation not only as fixation, but also as an anchor for correction. And then transiliac transsacral screws are not commonly taught in neurosurgery residency at all, in my experience. Do any of the orthopedic trainees in the room, have you have experience with those? Raise your hands. Yeah, any of the neurosurgery trainees do? We've got 0 hands, so that's about what my experience was as well. So these are important screws. They have multiple different indications, but for the neurosurgeons in the room, essentially transsacral transiliac screws are very useful in sacral fracture fixation. So we'll just very briefly touch on those. So although you certainly can do these pelvic fixation techniques with iliac screws and S2 alar iliac screws freehand once you're experienced, at least in the beginning, you'll be using fluoroscopy or navigation. And there are, indications for both, and one is not better than the other necessarily. And I think when you're first learning, navigation is really helpful to help you visualize the anatomy. But at the same time, you can't become dependent on navigation to do a technique. You have to be able to understand all the ways to do it. So using navigation really helps, and we're going to show you some videos with that today, but I think learning it with fluoroscopy is also really important as well. So I know many of you have placed pelvic fixation. Hands up if you've put in S2 alar iliac or iliac screws in your training. A large part of the room has done that. So this is a small screw for pelvic fixation, and I'm going to hold it up so the camera can actually see it. So 9.5 by 90 would be the minimal size of screw I'd ever put in with these trajectories. These are typically 10.5, 100, 110 screws to maximize the length and purchase. But the most important thing is doing them safely, which we're going to talk about. And to often realize that there's an ongoing debate, even amongst the highest levels of deformity surgeons who are very experienced, about what are the pitfalls of either. So both types of pelvic fixation, we're going to focus on iliac and S2 alar iliac, can fail. And one of the questions that remains is, do S2 alar iliac screws that cross the SI joint but don't fuse it, are they a mechanism of irritating the SI joint, or are they a mechanism of stabilizing the SI joint? And if anybody can answer that question now, I'll be happy to hand over the talk, because that's a hot source of debate. Recognizing that iliac trajectory screws don't involve or engage the SI joint in any way, so they're not violating the joint, which is great, but they are not stabilizing the joint either. So there's a possibility that iliac screws can irritate SI joint pain as well. So there's ongoing studies about both of these things. We have no conclusive data to this point about the answer to this, but I just want you to be aware of the sort of the ongoing debate about that. Traditionally, iliac screws had papers, we're talking maybe 10 years ago, 15 years ago, that focused on complication rates being higher. And that was typically because of the traditional starting point for a true iliac trajectory screw that was on the posterior iliac crest. And so it was prominent. It was also offset from the rods. And so you had to use a connector to join to the rods. And that's another mechanism of failure, that you could have a connector break. So that was the initial sort of source of the complications for iliac screws. Now, most people that put in iliac screws actually make their starting point subcrestal, which I'll show you, and that eliminates implant prominence, and it makes the iliac screws a lot more easy to line up with the rods. So some of those older papers about the complication rates have now been shown that that's not actually the case for iliac screws. And S2 AI screws really were popularized in the early 2000s by the Hopkins group, Dr. Kabesh, Dr. Sponseller, initially publishing in them, amongst others who were at the same time. And they had advocated that they obviated the need for a lateral connector because they line up well with your rods and they weren't prominent. So those were the initial advantages. So how we're going to do pelvic fixation, Dr. Sanser is going to go into this in great detail, so we're not going to spend a lot of time on this. But essentially, I want everyone, if you have not placed pelvic fixation, just to be aware of the general starting points for these different screws. And I think it's really helpful to think in basic terms. People often confuse the fact that I'm a neurosurgeon with the fact that I might be smart, and I don't think I'm particularly smart. I just like to understand things in a basic way, so we'll try to explain it that way. And recognizing that the iliac screw has a more lateral start point. And why is that? Well, because it's not going to engage or cross the SI joint. So it's got to get lateral to the SI joint before it even starts. So when you're in lab and you're placing these fixation points, really just try to visualize to yourself, you're not necessarily going to see the SI joint, but you certainly can feel where the sacrum runs into the ilium. That's a hard junction, right? So the SI joint is underneath there, even though you're not going to be able to ever see the whole SI joint. So you can start to just, as you're starting to learn these techniques, you can start to visualize this to yourself and use that to help you. Where the S2 AI screw actually starts, there's actually been a nice paper published out of here at Seattle Spine Foundation, and I'll show you that in just a minute. But essentially, if you find the dorsal foramen of S1 and S2, the S2 AI screw is going to start between those two foramen, not in either one of them, and it's going to be along the line of an edge, along the edge of a line that connects the lateral aspects of those two foramen in general. And there are lots of different advocates of different start points, and one is not particularly right or wrong, and you're going to hear some great thoughts from different people on it. But just in general, realize that's your start point. You have to know where the foramen is. How do you know? Well, often it bleeds a lot, and you don't want to put a screw directly through it because that certainly can be a source of pain or CSF leak, so try to avoid that. Dr. Sanser will go in a lot of detail about these screw trajectories, so I'm not going to belabor them, but one thing you might notice is certainly that the S1 pedicle screws are medially angulated, which all of us know, whereas these pelvic fixation points are laterally angulated. So typically when you're placing pelvic fixation on the patient's left, you're standing on the right side. Now, I'm sure that many of the attendings in the room can backhand it sideways and stand on any side, but I'd really really advocate when you're first learning these that if you were standing opposite of the side you're instrumenting for the iliac and the S2AI screws. And it's amazing that no one ever told me that when I was first starting to figure out these screws in lab as a fellow. And so I really got a good laugh out of my attendings when they came in the first time and saw me trying to put these screws in from the same side leaning over. So I'll just avoid that for you guys. Again, my mistakes can be your benefits. So I think one thing that's challenging if you're a neurosurgeon is that you don't get very much exposure to the ilium. During your training. And so basically it's learning anatomy all over again and trying to understand basically your target for these points of pelvic fixation. And I think a lot of our neurosurgery residents find that to be challenging. I don't know if you guys in the room remember that as neurosurgery residents. I think the orthopedic surgery residents and fellows in this room have a lot of exposure to the ilium for different reasons. And so you tend to have a more firm grasp of it. And it's in my experience, training fellows who are orthopedic, usually the pelvic fixation comes a little bit more naturally to them, but by the end of the year, everybody's on the same page. So don't worry if you're a neurosurgery trainee and this all seems Greek to you. You will learn it, and you'll learn it successfully, just like you learned the brain. It was a little more complicated, so don't worry about it. This is a paper out of this institution, and Dr. Sanser is going to do a great job of showing you how to line up your trajectories. But I just wanted to give you very basic views of this, because sometimes when you're projecting from the lab, it's hard to see the angulation of what his hand will actually be doing. So essentially, if you notice the picture on the left there, again from a paper out of here, the starting point, it's between the S1 and S2 dorsal foramen, and basically it's on the edge of a lateral line connecting them. And the kicker is you got to aim laterally and you got to aim caudally. And how much depends on whether the patient's male or female, because male and female pelvis have different shapes. It also depends on whether the patient has transitional sacrum abnormal anatomy. So there's not a number to be stuck on, but it's just a general inclination of 30 degrees and 30 degrees, and go from there on C-arm or on nav to try to find your trajectory for an S2AI screw. Okay, the iliac trajectory screw, which I am really good at technology and art, which you guys can see from the screen here. So the picture on the right, I take full credit for it. Isn't it lovely? That red line is an actual iliac screw trajectory, where the screw that's in place is an S2AI trajectory. And the beautiful blue squiggle is my depiction of the sacroiliac joint line. And that might seem basic, but for the neurosurgeons in the room, that's not necessarily familiar at first. So recognizing that the iliac screw is not engaging the SI joint where the S2AI screw crosses it is going to be really important when we talk about trajectory-related complications in a little bit. So I want y'all to remember that piece, please. All right, it's critical to understand what your targets are and what your pitfalls are. So, if you've never heard of what the iliopectineal line is, you've got to learn. If you don't know what an acetabulum looks like, that's your next thing to get. And the sciatic notch contains things you want to avoid. So that's the brief summary of what's critical about it. When you're placing screws from a lateral starting point for a transsacral transiliac screw, there's actually a really big risk that you can protrude through the sacrum anteriorly and catch the L5 nerve roots as they descend along the anterior aspect of the sacrum and give someone a foot drop. And our colleagues who do a lot of pelvic trauma, orthopelvic trauma at least, would tell us that their rates are definitely significant if they're doing that in enough cases. So that's something to be aware of when you're placing those screws. So again, more beautiful high-tech diagrams here, and I just want to point out on the left side, this is not a true teardrop view. It's actually a sort of a modified obturator outlet view, but it does depict the teardrop, and the gear-shift point is sitting in the center of that teardrop, so hopefully you can see that. The iliopectineal line on the left-sided picture is the red line, and if you violate that line, you are going to put a screw into the retroperitoneum, so please don't. The purple curved line is the acetabulum, and your hip colleagues will be upset if you consult them because you violated the hip joint with one of your points of pelvic fixation. So those are things to look at and avoid on the teardrop view. And just like you would never put in a pedicle screw by looking just at an AP or just at a lateral, you need to understand multiple views here. So the iliac oblique view here on the right, the red line depicts the sciatic notch, and certainly you need to stay above that because the things that live in the sciatic notch will make a long day for you. You don't want that. The patient doesn't want that. So those are the very brief things about iliac anatomy. So we talked about this picture just a few slides ago, and that red star represents the anterior aspect of the SI joint. And because all joints usually have corticated surfaces around them, the SI joint's no different. The cortical bone from the sacral half of the SI joint and the cortical bone from the iliac half of the SI joint basically create a thicker barrier to passing a probe or a screw or something, whether it's navigated or not, across it. And what do we tend to do when we have a firm barrier barrier, we tend to skive into areas that are not as firm. And what's not as firm is the retroperitoneum. It's going to provide almost no resistance if you'd like to go out the front. Thank you very much. And it's probably not something you ever want to do. So recognizing that the unique risks of the S2AI screw are that when you're crossing the SI joint, you have to be mindful if you're using a probe of the curvature of the probe, so curve it away from the retroperitoneum as you cross the SI joint, much as if you were placing a pedicle screw with a curved probe, you'd curve it away from the canal at first until you got to the neurocentral junction. So those are just analogous things to realize. And again, I know many of you know these things, but thank you for putting up with me explaining them. This is a really nice paper about trying to train people to put in pelvic fixation. So on the left is a view from one of my cases intraoperatively that we typically take, evaluating a teardrop and evaluating the iliac oblique. And on the right are some misplaced points of fixation. So you can see in the A part of the figure, that's a posterior breach, basically laterally. And the good news is there's not as many things out there that can burn you. But the real problem on figure part A is when you breach inferiorly or anteriorly, because you're either going into the sciatic notch or the retroperitoneum. And what that looks like is really well depicted on these C and D figures. You can see in figure C that screw goes right across the sciatic notch and violates it, right? And then you can see on D, it's actually basically going out anteriorly. So those are what we want to understand and avoid. If you don't know what these views look like, there's no way you can tell whether you're violating something. So very important. All right, so we don't have time to go through this entire movie, but basically what I wanted to show you, I'm going to stop the video, hopefully, and we're showing you navigated placement of S2AI screws. And the real-time movement of the navigation screen is up against my hand on the left side of the screen. And one thing that's important is understanding that the navigation views you get are not the X-ray views you get, they're not the X-ray trajectories you get, and you have to refamiliarize yourself with the anatomy. So if you look at those 4 quadrants on the navigation screen, the top left view, you actually can see this screw trajectory parallel and almost touching the sciatic notch, which is fine. It's fine to be very close to it. That's where the iliac bone is the strongest. If you look at the bottom left view in that quadrant of navigation views, you can see the view more in an axial trajectory across the SI joint. And you can see in that view, if you are not paying attention to where the probe that you're using is when you cross the SI joint, it'd be very easy to skive out. So we don't have time to go through this video any further. I'm happy to show anybody that's interested. Basically, just want to show you a couple of things about how this looks like in real cases. And the indication for this case is a patient who came to us with a very flat fusion. They had L5S1 flat ALIF cages and as well rigid fusion, so needed a 3-column osteotomy. Here's the plan. Here's the intraoperative execution of that plan. And then here's just the view of what the pelvic fixation looks like. These are 2 S2AI screws on each side for 4 points of pelvic fixation in a 4-rod construct. And that's sort of the final result. And just to give you an idea what this looks like on a CT scan intra-op, Dr. Stansu is going to show you S1 pedicle screws. There come those screws on the video. And then here are 2 points of S2AI screws for 4 total points of pelvic fixation. And that's what it looks like spinning through a CT scan. All right, so complications. The superior gluteal artery lives in the sciatic notch. It's the biggest branch of the internal iliac artery. You do not want to meet it, particularly with a sharp-edged screw. So avoid the sciatic notch. Any possible pelvic fixation complication I think I've seen, but one of the under-recognized ones is that the set plugs pop off. And if you're not really looking, your radiologist might miss it too. So you have to really look and see if those set plugs are dislodged on postoperative x-rays. And we actually had noticed that there was a fairly significant rate of this at our institution. I started wondering how bad of a surgeon am I? And we reported there was about a 5% failure rate within 6 weeks of the index surgery. And these were all large deformity cases. So we thought that was high and we engaged a multi-center study. And from 13 centers, guess what? It was still 5%. And so risk factors for that are if someone actually has residual sagittal deformity, of course they're going to have a higher strain in their pelvic fixation and be more apt to have failure. Using smaller screws is a risk factor for this. Lack of using an L5S1 interbody, transferring more strain across the lumbosacral junction without stabilizing the anterior column was also a risk factor for acute pelvic fixation failure. So just realizing that those things are modifiable risk factors. And here was an interesting thing. How far you tilt that set plug, tilt the head on your screw to accommodate your rod actually increases the strain across the junction of the set plug and the screw. So the more you tilt it, the more strain there is, and there is certainly a limit to how far that can be successful. And many companies are taking that into consideration now. How fast you torque off your set plug also matters. So actually doing that really fast thing where you just torque it off really quickly, it basically confers less stability to the set plug screw interface than if you torque it off over about a second, so slow and steady. And basically that was something that we used to change our practice, and it was a lab study that we did that was really interesting. So in summary, spinal pelvic fixation fails more often than we commonly realize. I didn't even realize as a fellow that it could fail because it looked like such an enormous screw, but there is a significant rate of that, and these are the things you can do to try to help prevent that. And if you have failure of your pelvic fixation or failure of your S1 screws and you need pelvic fixation, most patients can accommodate 2 points of S2AI screws on each side of their pelvis for a total of 4 points of pelvic fixation. Additionally, you can use iliac screws or you can use those preferentially. So that's really quite common. We do it all the time. It's not unusual at all. So I just wanted to mention that. Thank you for your time.
Thank you.